Hi.
Hi, hold on a second. I just lost my thing here. Okay, great. Yeah, welcome. This is Dr. Wen with the Department of Geriatric Medicine at CHAPSOM. Thank you for joining us again at the ECHO Long-Term Services and Support COVID Preparation Series. Special thanks to our collaborators, Hawaii Emergency Management Agency, HAH, Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. We usually have a brief presentation and then open up for a time of questions and discussion up to 3 p.m. And we ask you to use the chat box to submit and queue up your questions. Next slide. This is a schedule for our upcoming sessions. As you see, next Wednesday, we will be talking about updates on COVID testing and surveillance. And I'm sure lots of you have lots of questions given recent CMS guidelines. And then we have a couple of other good topics coming up for our care homes, long-term services and supports, and strategies to protect home care providers. So, make sure you joined those sessions. We will be offering CMEs, and nurses can use for CE purposes as well. And we are also offering certificates of attendance to all participants who complete an evaluation. If you haven't registered, it's not too late. We encourage you to do it after the webinar. And evaluations can be found on our website under the evaluations tab or by following the link in the chat box. At this time, please enter your name in the chat box for attendance purposes. For all of you calling on the phone, we ask you to please unmute yourself and tell us your name, and we can write it down. So let me take a look in the chat box, look at our participants and see who we have here. We have folks calling in on the telephone. We do have a number of people on the telephone. So I'm going to see if you guys can unmute yourselves and just tell us who you are. I'll give you a sec. No? You guys, you're too shy.
Rosalani, based on Maui.
Okay, great. Which number are you?
It's a 808, maybe 871-7720.
Oh, okay. All right. Anybody else calling in? No? Okay. All right. Hopefully you'll put your names in there at some point or fill out the evaluations. That would be great. Okay. Anyway, introduction. So today we will be talking about COVID-19 reporting and tracking logs. And this is really, really important. So we're hoping that you guys have lots of questions today. So without further ado, we're going to have Caitlin Cook, who's from the Hawaii Department of Health, Doc D department, and take it away.
Hi, thanks. Can everyone hear me?
Mm-hmm.
Yes.
Great. Thanks so much for having me today. Next slide, please. Today I'm going to start by going over the recent MMWR article that detailed one outbreak in a skilled nursing facility in Los Angeles County. This is a 150-bed skilled nursing facility for veterans. It has 3 patient care areas in 2 buildings. Wards A and B are in Building 1, and Ward C is in Building 2. There are no common areas between the 2 buildings, but residents may have indirect contact with outside persons while receiving medical services such as dialysis. These wards admit residents who require IV antibiotics, complex wound care, other rehab needs, etc. And the residents have underlying conditions such as COPD, chronic kidney disease. Conditions like this are common. The setting and layout of the building is important for epidemiological investigation, so I'll just try and add my commentary throughout telling this story and share that when we're working with you on an investigation, sometimes providing us with a map of your facility can be helpful so we get a better sense of the layout of the facility. Next slide, please. So this facility had already been preparing. They had some infection control infrastructure already in place. On March 6th, they began screening all staff and visitors for symptoms. They asked about travel history, and they asked about close contact with persons suspected or known to have COVID-19. By March 11th, they halted all admissions and began daily temperature and symptom screening of the residents, and initiated their plan that anyone who had signs and symptoms would be placed immediately on contact and droplet precautions. On March 17th, they prohibited all visitors from entering. Next slide, please. So on March 26th, which is 9 days after the visitor restrictions were put in place, they identified the index patient who had a fever, and they were a resident in Ward A, which is in Building 1. This patient was placed in immediate isolation, so contact and droplet precautions, and they also had an NP swab collected that same day. The next day, March 27th, the second symptomatic patient was identified who also resided in Ward A of Building 1. This patient had a fever and a cough, and also had an NP swab collected the same day as their symptom onset, so on that day, March 27th, and was also immediately placed in isolation. At this time, the facility immediately halted all staff floating by assigning them to specific wards, and also the infection preventionists began regularly auditing PPE use on the wards. Next slide, please. The facility then initiated aggressive testing in response to the two identified cases. They tested all residents of Building 1, which is where Ward A was located, over 3 days, March 29 through 31st. So Building 1 includes Ward A and Ward B. So Ward A and Ward B both had 30 people each. So in Ward A, 4 out of 30 residents were positive, and on Ward B, 0 or none out of 30 residents were positive. But on March 29th, a third resident actually became symptomatic. This person resided in Ward C, which is in the other building, Building 2. So this prompted testing for all 36 residents of Building 2. Of those, 10 were positive. On March 20th, just a side note, March 26th, the date of onset for the first case happened to be a Thursday. The 27th was a Friday. And by the 29th, when they initiated the mass testing, this was on a Sunday. So this facility had the capacity to test the symptomatic residents immediately on the same day of symptom onset and identification, and they were able to begin mass testing just 3 days later. Next slide, please. All right. Because positive results came from wards A and C, this facility initiated approximately weekly serial testing until no new residents received a positive result. After they did their first round of testing, they actually identified Ward A to be the COVID unit. So this is how they implemented their cohorting. So they moved all of the COVID positive residents here. So 6 were already there because they already resided on Ward A when they were identified. But based on my math from the outbreak summary, I think they had to move 5 residents from Ward C into Ward A to be part of the COVID unit. And so then they also obviously had to move the Ward A residents who were negative out into wards B and C. As an aside, at the beginning of the MMWR, they do mention that at the time of the outbreak, the facility had 66% of their beds were occupied. So it seemed like they had some vacant spaces to kind of maybe assist with the shuffling. They retested Ward C again on April 6th, and they identified 2 new cases. They tested again on the 13th, and all Ward C residents were negative. They tested again over April 22nd to 23rd, and all Ward B and Ward C residents were negative. Next slide, please. So in summary of the resident cases, 3 residents were initially identified by symptom screening. I didn't mention this earlier, but all 3 of those residents were transferred to the hospital. The MMWR actually at the bottom lists the facility's criteria for transfer. So they had pretty stringent criteria that would trigger transfer to the hospital. I don't have that in these slides, but I'd encourage you to go take a look. So these 3 symptomatic residents that were initially identified were isolated right away within the skilled nursing facility, but then they were ultimately removed from the skilled nursing facility by going to the hospital. And then subsequent testing identified 16 additional resident cases for a total of 19 cases, so the 16 plus 3. 14 of these were asymptomatic at the time of testing. So that means that we have those 3 original symptomatic cases, and then 2 additional residents were found to be symptomatic at the time of testing. So that's 5 that were symptomatic. Of the 14 who were asymptomatic at the time of testing, 8 went on to later develop symptoms. So they were actually pre-symptomatic, not truly asymptomatic, just asymptomatic at the time of testing. And then unfortunately, 1 resident, a man aged over 90 years old, died. Next slide, please. So what about the staff? So they also initiated universal testing of all 136 staff members. I think for this outbreak, they kind of had to, because they had identified resident cases in both buildings throughout the facility. And they hadn't yet halted staff floating until after some of the staff could have potentially been exposed. This will be assessed situation by situation. Of these 136 staff members who were tested, 8 were positive. I don't have it in the slide here, but 3 were RNs and 5 were licensed vocational nurses. 4 of these 8 were symptomatic, so 4 were asymptomatic. 1 actually developed fever while they were at work. They were immediately tested and then also sent home. I think this makes a case for more frequent symptom screening, or at least strong messaging to your staff that if they develop illness while at work or during a shift, they need to be able to immediately self-isolate, notify their supervisor, notify infection control, and be sent home. This facility did not conduct serial testing of staff members due to resource limitations, but they noted that testing remained available for any staff member who became symptomatic. Next slide, please. So in summary of this little outbreak, so thorough symptom screening identified the first case and then the subsequent additional 2 symptomatic cases. They had a plan that they were able to rapidly deploy to test the symptomatic cases and then also the affected wards. They were which informed their ability to cohort the residents based on their test results. They completed serial testing until no new cases were identified. And then throughout, they had strict adherence to infection control, hand hygiene. They implemented no floating of staff, and they mentioned a few times that the infection control nurse became heavily involved in auditing PPE, appropriate PPE use. Next slide, please. I took a lot of this text straight from CDC's website. I'm sorry, I think I realized right before this, some of my footers got removed from the slides, I think when I added the slide numbers, but this is from CDC's website, besides the last row, which is the disease reporting line for Hawaii. But CDC does recommend actively screening all residents. They say daily, I think at least daily, for fever, symptoms of COVID-19. And then I added our disease reporting line at the bottom there. That's our 24/7 number to please give us a call as soon as you identify any suspect cases through your symptom screening. Next slide, please. So I'm going to talk a little bit about keeping a line list. Some of you may be more familiar with this if we've worked with you in the past for a flu outbreak or another outbreak in your facility, but this may be new to some folks. So a line list is a table that contains information about each case in an outbreak. So in the table, each row is a case, and each column is for certain demographic, clinical, or epidemiological information. We keep the line list for every outbreak, and so we'll request updates from someone in the facility at least daily to share with us the updated line list. We prefer if you share it in an electronic version, such as Excel, so that we can easily edit it as opposed to, faxing it over, which is what we're used to, faxing a lot. But we prefer receiving it over Excel or over secure email in Excel format. It can be quite burdensome, especially if the outbreak grows. There's a lot of information on the line list. So it would be great for us if in the facility they identify a point of contact who will be in charge of keeping the line list updated and making sure it gets shared with us at least daily. Next slide, please. For a COVID-19 outbreak, I listed here the required elements. So these would be each column in the line list that we need to know for each case identified in a COVID-19 outbreak. A lot of it is fairly standard and similar to what you would see with like a flu outbreak line list. Name, age, date of birth, sex, room number and location is really important. Symptom onset date is very important. If someone is asymptomatic, indicate as such in the line list. You guys can read through, but we need information on signs and symptoms, underlying conditions, testing, the date of specimen collection, the test result, if the resident was transferred, if they were moved anywhere else, and then outcomes as well. I'm going to talk a little bit more in the next few slides about the differences between a line list for staff and a line list for residents. There are a few different ways we can do this. You can either have a column in your line list that just indicates if they're a staff or a resident. So we need to know somehow if they're a staff or a resident. But we do need slightly different information for the staff members. So I'll go over that in the next few slides. So next slide, please. This is an example. I tried to fill in a line list with the data from the MMWR outbreak. It didn't have all of the data that I needed, so a lot of this is just made up. Columns A, B, and C, name, age, and date of birth. For the rows that are empty, I just didn't feel like making out fake names and date of birth, but it does need to be filled out for every row. You can see room. So I put in the first three. So it was that initial patient. I made up an age and date of birth, but they were in Ward A, Building 1. Specimen was collected on March 26th. It was positive. Symptom onset date was also March 26th. First documented symptom was fever. This is just a screenshot of kind of the first part of the line list, but it continues with all of the other columns with the information that I had on the previous slide. Let's see. This, you can see how the line list really has to be kind of a living document. All this information, really can change. People that are initially asymptomatic might go on to develop symptoms. People might have different symptoms develop. People might be tested more than once, so have different testing results. So you can see how this really can grow and change over time. And so it's really important to get updates from the facility at least daily for these. Let's see. Last word about the residents line list. This is for folks that are included in the outbreak, basically because they meet the case definition for the outbreak. So these are cases. We can work with you on creating a case definition, but basically it's people with a positive COVID test result, or in some cases we'll include probable cases, so people that have compatible symptoms, a strong epidemiological link, and then for some reason they weren't tested if there's a testing supply shortage or something like this. But we have strong evidence to include them as a case. We would include them here. Next slide, please. Staff line list, it's the same concept, but we just need slightly different data elements for the staff members. I've put stars above the columns here, kind of interest, where we need to know the role of the staff member. We need to know what areas they worked in. If the information is available, we need to know if they work in other facilities. And then we also need information about the dates that are worked. This is to kind of help our understanding of the outbreak, help us understand modes of transmission or possible introductions or index cases in the outbreak. So we do need, slightly different information for staff versus residents. So just wanted to let everyone know about these kind of different data elements. You can either put it on all one line list and just indicate staff or resident and just leave these fields blank for the residents, or you could do it in one Excel workbook and have 2 different sheets. However you prefer, but this is the information that we're going to need to collect. Next slide, please. So that's not the only thing we keep track of. We do need tracking logs of everyone tested. So this is for our denominators, so we can determine an attack rate in the facility. So if someone's tested and they're negative and they're asymptomatic, they won't meet our case definition, so they won't be included on the actual line list for the outbreak. But that doesn't mean that we just forget about them. We'd like to ask you to please keep a log of everybody who is tested and include some of these data elements that I have here. So at least name, area or unit, date of specimen collection, and the result, and if they are symptomatic or not. So just want to let everyone know that that's one of our expectations as well, to keep track of everybody tested. So it is a lot of work when there's a lot of testing going on. It can be maybe burdensome to keep track of all of the information, but we'll help you with it, and it's important to collect all this information. Next slide, please. That kind of wraps it up for the information that I wanted to share on that topic. I also wanted to share with you guys some of the recently updated CDC guidance. If you're like me, it's nearly impossible to keep up with all of the changes. I don't know if you know this trick already, but if you Google CDC what's new in your internet browser, the first link that pops up is a list from CDC of all of the updates by date, starting with today and going back in time. So it's a really quick way, at the end of the day or the end of the week, you can just kind of Google that and see if there's been any new updates that are relevant for you on the CDC's website. I've put hyperlinks here. I think these slides will be shared for some of the, I think, relevant guidance that are being updated quite frequently. So feel free to click around on these guidances too, and make sure you stay up to date. Next slide. That's all that I had prepared for today, but I wanted to share my contact information. That's my email address, and that's my direct line phone number, 587-6581. But the disease reporting line, which is where you can reach someone to report a suspect case 24/7, is 586-4586. So you can call me for questions about infection prevention and control, kind of non-emergency situations, guidance, planning, things like this. And then if there is an outbreak, I'll be working with you quite closely. But to report cases, make sure you call the disease reporting line, so you'll make sure you get a live body. That's all I had, but we have plenty of time for questions. So.
Okay, great. Well, we do have a question from Maria Castillo. What about staff that work in other settings, right? As our communities reopen, if they work in a restaurant or the airport, for example, should we list that, or only if they're in another healthcare setting?
That's a great question. I think if you know the information, feel free to include it. This is also information that we'll gather as part of our case investigations. So every case that's reported to us gets assigned to an individual investigator, and they'll do the community-based contact tracing. So I am optimistic that this information would still be gathered through our normal contact tracing and case identification means. But, by all means, if you happen to know, sure, that would help us too.
Great. Yeah. I'm going to assume that a similar line list should occur for every healthcare setting, not just nursing homes, right? Like assisted living facilities and even care homes, right?
Yeah, definitely. So every, the line list is really the backbone of almost every outbreak we investigate, even if it's not in a healthcare setting, but we created a line list for, restaurant-associated clusters, everything like this. So the healthcare-associated clusters just require slightly different data elements, like room number where someone resides and things like this. So it's just a little bit different. But for the healthcare facilities, yes, indeed.
Okay, great. Hi,
One
Sarah.
other point I just wanted to add is that one of the things we would work with a facility on right away if you suspected a cluster of illness in your facility is defining who goes on that line list. So making a case definition is always one of the first steps. And in general, it's not just going to be people who test positive, it's also going to be people who meet certain symptom criteria. So depending on the specific situation, we'll decide if that requires, you know, cough and fever or just cough. Is it new cough? Because a lot of the residents might have cough already. So those kind of things go into that process of deciding who goes on the line list.
Yeah,
Okay.
that's a great point.
Okay, Dr. Yazawa, can we assume what happened at the LA example that you just provided will be what our DOH will do if we have a COVID in one of our skilled nursing facilities?
Yeah, I think at this time, what they've outlined in the MMWR is a great model for an aggressive response. Obviously, every facility is different, and as the situation changes, you know, we'll have to kind of adapt. Right now, we have access to testing, things like this that I think enable us to do a similar response to what was outlined in the MMWR. Like I said, we might not always do universal testing of all staff right away. I think we would look at where the cases were, if there were any like logical separations, if it was concentrated on one ward or unit where staff weren't floating, it might make sense to start with those staff. And then if they're positive, kind of continue testing in almost like a ring approach. So, you know, it might vary. I think if we had this situation that was outlined in the MMWR, I think we would do something similar. You know, as I mentioned, because they had cases in both buildings, staff were floating between both buildings. I think in this situation, it really made sense to universally test all staff for that outbreak, but that might not always be the case, kind of depending on, you know, each individual case, cluster, or outbreak.
One reason I really like the LA story as a way of getting people thinking about what if this were my facility. This is a really good time to sit down and take out the map of your facility and think about it and think about where your staff float between. And just imagine different scenarios as part of your planning process of, let's say I had a case here or a case there. How many people does that mean might be exposed? If you've thought that through before you have your first case, by the time you call us, you're already going to have an idea of what your plan is. And we're going to talk more about this next week when we talk about testing plans. But that's part of having a testing plan, is understanding where a case is going to necessitate testing, 30 people, 60 people. And any planning that you do now to minimize and modularize how many people are going to need to be investigated right away as first priority, the better off you're going to be if you end up having cases in your facility. So we'll talk more about that next week.
Okay, great. Question here from Dr. Zawa. Will we be moving forward with the point prevalence testing for SNFs? I know this is next week's topic, but we could talk about it today too. What are the key lessons learned as well?
Key lessons learned from
the LA case.
Oh, yeah. Well, I'll let Katie take that one. Just to address the question about point prevalence surveys. Given the new CMS guidance and requirements, all facilities are going to need to come up with a testing plan. So we'll be working, that's part of what we're doing in our outreach through the tele-ICARs, is talking about testing plans. We're working on a more checklist type guidance, which we hope to have I guess by next week we're trying to get that tidied up, so it's going to be a good usable tool for everyone. So that should be coming in the next week. But in terms of point prevalence surveys, we are looking at submitting an IRB to do a limited pilot of point prevalence surveys, which would also involve a little more data collection on the front end as well. Since right now we are at low prevalence, this is a good time for us to try to do that, where we can also understand the patient populations we're testing. But that will we have to run that through IRB and get that through. So we're hoping to have updates on that by when we talk about testing next week as well.
Yeah, thank you. Key lessons learned from this LA case or this LA outbreak. You know, there were quite a few. I think they did an excellent job with their symptom screening to be able to identify these initial cases right away. They were able to test the symptomatic people on the very same day. They were able to immediately isolate them. They must have had a good plan for cohorting because they were able to implement it quite soon after identifying the initial cases. They were able to identify that ward, Ward A, as kind of being the cohort or the COVID unit. What else? The strong emphasis on infection prevention and control. So having staff trained, ready, once identified a patient who was ready or who needed to go on contact or droplet precautions, they were able to implement that right away. They mentioned the infection preventionists being out on the floors, auditing the PPE use. I think the close eye on the residents, identifying symptomatic residents right away, and then following up with rapid and aggressive testing to identify other cases and inform the cohorting, I think was a great lesson learned from this outbreak.
Yeah, to me, one of the key lessons learned is really that the importance of that active surveillance piece, that knowing that you're going to pick up symptoms early and then be able to respond is part of the response plan, a really important part of the response plan. The other thing that may be a lesson learned is I didn't see mention that they had universal source control masking in place at the time this happened. And so I suspect if it had been, it would have been even more slowed down, or maybe a much more limited outbreak.
That's a great point. I don't think they mentioned that in the MMWR either.
Yeah, I was actually kind of just wanted to maybe highlight or note that this kind of went on for a good 6 weeks, and this was a pretty good scenario.
Yeah, well, and it does because of the nature of our testing toolkits, right? So as you serially test people, we know that people can continue to be positive by PCR for a long time. And that's still the state of the gold standard of testing right now for COVID. So and we've seen this in the healthcare setting clusters that we've had in Hawaii so far too, that it takes a long time till you get to say you're really all clear. I think that's an important expectation to set, that once you set out on one of these investigations, it's a pretty long process. Even if, even if new active disease is slowing down quickly, you'll still have that tail end of follow-up for quite some time.
I just want to mention that if you go to our website, under the resources that you can download, if you click on the link, you can actually just get a copy of this Excel spreadsheet there that you can just download and use.
Great, thank you. I think the one I shared for that is, one workbook, and then it's 3 different tabs. So one tab is the resident cases, one tab is the staff, and then the third tab is the other list I talked about, which were the people that were tested but didn't meet the case definition. So they were likely a negative test that we also want to keep track of.
Great. Well, thank you, Michaela. She just put down the website that everybody can access those resources. Okay. Any other questions?
If you guys haven't read it yet, go back and read it. It's a pretty good story, and there is some information that I didn't share in the slides here. I thought it was really interesting at the end. They really listed out the criteria that they had for a resident to be transferred from the facility to the hospital. They had the criteria for the transfer from the hospital to the facility, and they had the criteria from the COVID unit back into the regular wards. So I didn't share that here, but I think it might be nice if you're looking for an example or something like that, take a look and see what they did up there.
Okay, great. All right, any other questions? I know we mentioned that even last week, or I forgot, the other week, that there is already a requirement for reporting for NHSN, and then this as well. But I think that these actually complement each other. And if you could just clarify, this doesn't actually need to happen until you start having symptoms. Is that right? Correct?
Yes, so this is kind of our initiation of our case or outbreak investigation. And so once you have a suspect or a confirmed case, that's when we would initiate this kind of aggressive response. We'll start asking for the line list. You'll be hearing a lot from us. The NHSN reporting, it's a little bit different. I think the requirement is at least weekly, and so it's a little bit delayed. So they're two pretty distinct reporting streams. So for suspect or confirmed cases, give us a call on that disease reporting line and we'll start this process.
Okay, I think NHSN also has reporting elements regarding the staff, right?
I think that they do. Yeah. I think the NHSN, it's also a great source of the data, but because facilities are only required to report weekly, it just can be a little bit delayed. And so we don't want this to be our main source of learning about new cases that we need to respond to. It's more about, tracking trends over time, making sure we're not missing anything, understanding facility capacity, things like this. That's kind of more what the NHSN data will be used for, rather than like our regular disease reporting systems.
Okay. Do people have any other concerns about this or questions?
I have a question for the group. This facility, I think they mentioned that they screened the residents for symptoms once daily. I think in the iCar tool we're using, that Carol and our team is using to outreach to the facilities, I think it says 3 times daily. I'm curious, in the facility, what's feasible? Is 3 times too much? I think 3 times might be, once per shift. What are you guys doing out there? Are you doing once, twice, 3 times more?
All right, chat away.
Once per shift at Maluhia. So that's 3 times would be once per shift, twice a day, every shift, twice per day. So it looks like 2 to 3 times per day is what's happening. Okay. Okay, yeah, that's helpful. Thank you.
It also looks like to me that this LA case, they didn't actually have a COVID designated unit at the beginning.
So it's not crystal clear in the MMWR. I think that the first few cases, I think they just transferred them to the hospital. And I'm not entirely sure, because we don't have great visibility into like the entire clinical picture, what exactly happened. But it's true, it wasn't until, I can't remember off the top of my head, but April 3rd or April 6th that they had designated the one unit as a COVID unit. And it was also that same unit that they brought back the patients that were hospitalized and then discharged from the hospital back into the facility. They put them in that same unit. So yeah, it's not crystal clear from the MMWR, but if they had that plan the whole time, or if they realized that they needed a place for the people to go, but they did get it going, I think, quite quickly.
Yeah, it took them like a week, right? So, but if they had one in advance, or if they had one that they could just put together within 24 hours, that may have been more ideal.
I think so. And because we don't know about those 3 cases that were sent to the hospital right away, I'm wondering if they had had a safe place to put those 3 cases within their facility. This is just speculation, but they may have avoided transfer to the hospital, which, you know, with a if they need to be transferred, they need to be transferred. But if they're transferring just for isolation, then you risk exposure for EMS or transport staff. It's a road we don't really want to go down unless we have to. Oh yes, they did mention that the facility was 66% of beds were occupied. What are our facilities like? I don't think I have a great sense of, is 66%, you know, it seems kind of low. So it seems like they maybe had a little bit more space to kind of shuffle people around, but 90 plus, Dr. Drees always said, yeah. So that, you know, maybe helps them in that outbreak. It might be a little bit trickier for some of the facilities that have higher occupancy.
Yeah, did they ever figure out where the case came from? Was it from staff?
They didn't
Was
say.
it
Um,
a new admission from the hospital?
You know, they really didn't say. I was looking for that. I think I said it was 8 or 9 days after they closed to visitors. So I guess there's a small chance it could have been a visitor, you know, and then that 14-day incubation period. But I can't remember off the top of my head. I think the staff, I don't know actually the staff symptom onset dates off the top of my head, if it makes sense that a staff member brought it in or a new admission. I'm not entirely sure. And that's sometimes the frustrating thing is that sometimes we don't know and we never really pinpoint an exact source sometimes.
Yeah, no, this is a great example, and it gives us a sense of what we might expect if indeed something would happen. And it's kind of reassuring to know that it's not just universal testing for everybody, but a little bit more informed.
Yeah, I think it really showed how smart but aggressive testing can really inform the response to the outbreak.
Mm-hmm. So every facility should have a strategy for how to get aggressive testing done once this whole thing starts. Right?
I do think so. I think that's part of what Dr. Campbell was mentioning, getting your plan together, making sure you can do this. We're here to help and we'll help as much as possible, but having your own facility plan will definitely be helpful if the situation occurs in your own facility.
Great.
Yeah, I mean, state laboratory resources are available to assist in an outbreak setting. But you can imagine if we were to get to a point, hopefully we don't, knock on wood, but where you have multiple long-term care outbreaks going on at the same time, you wouldn't want to be solely reliant on one, on the state lab to do everything. So I think it's important to also have strategies to get an initial round of testing done or certain rounds of testing done, so that we can make sure there's no delays.
It's my understanding, though, that most facilities have their own contracts with their own labs, like DLS or clinical labs, and so it's really up to the nursing staff to do all of the whole testing for the whole building and for all the staff. Is that right?
Yeah, and most long-term care facilities are going to be going through their contracted labs, and that's what your plans should hinge on.
Mm-hmm. Okay. Oh, you mentioned reporting suspected cases. Could you define suspected? Does this include residents tested for COVID as a precautionary measure?
So I'll start with the second question. No, I think it's a little bit of a judgment call here. So we don't need every single test reported to us. I don't know if we have the manpower, the bandwidth to accept all of that information. But we do need to know about anyone where there's a real clinical or epidemiological suspicion that it's an actual COVID case. So, you know, I understand it is a little bit of a judgment call. I think in some of our previous ECHO presentations, Dr. Wen or other presenters have outlined criteria to consider testing for COVID. So I would say if someone meets that criteria, like a new symptom or a worsening of a symptom or any change in status where you think, okay, this really might be a COVID case, definitely report those to us. If they're being tested for any other number of reasons why people are being tested these days, I don't think we need to know about.
Yeah, I think the way I would frame this, if you have someone where you have reason to believe, for instance, they may have had contact with a known COVID case outside the facility. They just had a visitor who was obviously ill from a COVID an area where COVID is having high rates. If there's a specific reason that you're very suspicious the resident may have COVID, it's always better to err on the side of calling us. We're not going to be like, oh, you shouldn't have called us. Like, we'd rather hear about a concern. That being said, if somebody's coughing a little during feeding and they're a known aspirator and you're just sending the test to be sure, but there's no apparent exposure, we don't necessarily need to hear about every one of those. But if you have 2 or 3 of those that are all roommates or next to each other in rooms, maybe that's a time to call the health department. So it's a little bit of a judgment call, but I'd say definitely if you have a cluster of unexplained respiratory illness on a particular unit, then definitely call. And cluster would be even as few as 2 if you have 2 people coming down with fever and cough in adjacent rooms in the same day or within a few days of each other. Doesn't hurt to call, and we can start looking into it then and thinking through cohorting strategies if you don't have testing results back, all of that stuff. And then if you have somebody with a strong clinical suspicion, so patient just transferred out with very severe respiratory disease, there's a very strong concern for COVID, that's something we'd want to hear about even before you know testing results. Beyond that, it's really confirmed cases.
Great. Any other questions? Anybody else on the telephone who wants to identify themselves so that we can take attendance while we're waiting for more questions? Okay. All right, so you guys are very quiet, but I'm sure you'll have come up. Hopefully you'll join us next week and we'll have even more discussion about testing as well, since we're going to be talking about things about like universal testing, point prevalence, testing for clearance, and all kinds of updates on that testing issues to help kind of complement today's session. Okay, just gonna leave this up just a little longer. It's last minute questions. Does everybody feel ready? Are there still areas that you feel a little uncertain about that you would like us to cover in the coming weeks? That you'd like to just hash over again and talk with our experts? Please just type that in the message box and we will certainly talk about that. I think coming up, we will be talking a little bit more about care home support as well as home care. And I think we'll also be coming up talking about opening up strategies for relaxing visitor restrictions, things like that. So yeah, please, we want to be able to meet your needs. So please let us know what you would like us to cover. Okay. Okay. Well, anyway, looks pretty quiet. Oh, all speakers are excellent. Oh, thank you. Thank you.
Well, thanks for having us today. You have my contact information by now, I think, so don't hesitate to reach out.
Yep, and we're all working together. We're really trying to set an example for the rest of the United States. I think we want to be the only state in the entire country, right? And showcase us. We have the best response because we're all prepared, and we can shut this thing down if it ever gets in. And hopefully we won't have it get in anywhere, in any one of our facilities or assisted living facilities or anything. So thank you everybody for joining us. Continue to spread the word so that we can be as maximally prepared as possible. I really think you all are great. So thanks, and we'll see you next week. And please don't forget to complete your evaluations and download resources. Okay, take care. Have a great week.
Thank you.